Good morning, everybody. I introduce myself. I'm Esther Ramos, a pediatric gastroenterologist of this hospital, Hospital La Paz. I am a member of the Intestinal Rehabilitation and Transplant Unit, and I'm going to talk you about a clinical case that we live, it's an old case, 10 years ago, more or less. I will try to be brief because I know it's late, you will be tired and hungry. So this is a woman that was diagnosed on Gardner syndrome when she was 10 years old. About his family history, he has a mother that was healthy and alive, but his father was also diagnosed of Gardner syndrome and died when he was 48 years old due to a colonic adenocarcinoma, frequent complication of this syndrome. He has another brother that affected also with Gardner syndrome that underwent a prophylactic colectomy when he was 26 years old. And he has also a brother and a sister healthy. When she was 13 years old, he underwent a prophylactic colectomy in another center. And at 16 years, he developed a desmoid tumor. Chemotherapy and radiotherapy was indicated, but it has no response, so he was referred to our unit. In our center, laparotomy was performed showing an unresectable desmoid tumor, so she was included in waiting list for intestinal transplant. 1 year later, she received a modified multivisceral transplant. I think you will know, most of you, that a modified multivisceral transplant includes stomach, small bowel, and pancreas, but not the liver. And in this case, the spleen was included in the graph. I remember you is an old case. Now we don't include it because the complications you will see after. The donor was a boy of 12 years old on 60 kilograms of weight. The cause of death was aspiration, and the graft ischemia was more or less 9 hours. He received the immunosuppression protocol at this time, consisting of methylprednisolone 10 milligrams per kilogram of weight in the reperfusion moment and the day 1, and then tapering. Basilizumab as induction 3 doses on day 0, 4, and 8, and tacrolimus with steroids in the maintenance. He was admitted in the intensive care unit only for 6 days with no relevant complications, with the exception of intra-abdominal abscesses 2 weeks after intestinal transplant that needed drainage. He began oral nutrition at 8 days after transplant with good tolerance, and he was able to wean off parenteral nutrition 1 month after surgery. At this time, she saw the reactivation of Epstein-Barr virus. He was positive Epstein-Barr virus and cytomegalovirus prior to transplant. And 2 weeks later, NS-Sanctem appeared. It was inspecific, and he was diagnosed of doubtful drug RAS. But he was doing well, so 2 months after transplant, surprisingly, he was discharged of the hospital. This is not usual in this kind of transplant, I say. So this is at the moment the evolution of the patient. But 2 weeks later, he was admitted again because the RAS was worse and with mucosal involvement. A skin biopsy was performed, and he was diagnosed with graft-versus-host disease. So we put steroids 1.5 milligrams per kilogram a day, but he doesn't improve. So 3 months after transplant, there was also fever and thrombocytopenia, neutropenia, and anemia. So thinking about an autoimmune disorder, we indicate more high doses of steroids and gamma globulin and GCSF. Tacrolimus level was optimizing, and in that moment we make karyotype in blood because at this time we have no other form, other way to monitor inside the chimerism. Remember that there was 10 years ago. Unfortunately, the donor was a boy, so and she was a girl, and we find a cytogenetic study with a 71% of male karyotype on blood. But she didn't improve. The RAS get worse, the hematological disorder get worse, the mucosal impairment get worse with esophageal involvement, as you can see in this photograph. This is esophagus. At this time, a cytogenetic study reveals 88% of chimerism. So we prescribed 2 doses of basilizumab with no improvement, so splenectomy was indicated. Remember that the spleen was also grafted. With this intervention, we find a partial response, but only transient. 5 months after transplant, cutis affection increased. This was the aspect of the patient. So, given the severity of the skin, we use alefacept. In that moment, it was almost experimental treatment using graft versus host disease. We are always we use the stem cell bone marrow transplant as a model because it's the organ more similar to our, in this case, of complication. So we use this, and this was the findings of cytogenetic study. But as you can see, the last one, after treatment, he shows 90% of male karyotype, but clinical, it was a very big improvement. But it doesn't finish yet. 2 months later, 8 months post-transplant, she began with fever, diarrhea, oral ulcers, and in the endoscopy was performed, finding a severe ulcerative duodenitis. On blood, PCR was positive for Epstein-Barr virus and cytomegalovirus, and in oral mucus was positive for herpes simplex. And this is the aspect of the duodenum. As you can see, it's a bloody duodenum, ulcerate, with a severe infection. We are scared to do this, but we need it because it can be also a rejection. Simultaneously, he began with anemia with direct comes, sorry for the mistake, positive, so she was a diagnosis of hemolytic anemia. We start using ganciclovir, gamma globulin, and steroids. But he doesn't improve, she doesn't improve. 1 month later, he reached up 3.8 grams of hemoglobin, with very general affection, headache, sick feeling, abdomen was very low, and we find both IgG and IgM cold agglutinins. So we use again steroids, again gamma globulin, and we switch off to sirolimus, but with no improvement. Several rats, itching, big anemia, refractory anemia, and in this moment we use rituximab, and with this treatment we get graft versus host disease improving, and alemtuzumab, so anemia resolution was reached. Surprisingly, with such an intensive immunosuppression, Epstein-Barr virus and cytomegalovirus became negative. More. 15 months after transplantation, she developed prolonged fever lasting more than 1 month with any specific findings, elevation of acute phase reactants, but nothing more, no graft versus host disease. The study of fever was absolutely negative. So broad spectrum antibiotic was indicated, but he has no, the same fever with asthenia. The only finding was low IgM level, probably due to the immunosuppression, to the depletion made before. So a bone marrow aspiration was performed, finding a caseatin granulomas with PCR positive for Mycobacteria tuberculosis. It's not surprising with such an intensive immunosuppression. So he was diagnosed of miliary tuberculosis, and tuberculostatic chemotherapy was indicated. 3 years later, everything is asymptomatic. This is the time when he went to an adult unit. She has asymptomatic, no graft versus host disease, no hemolytic anemia, non-active viral replication, and a fantastic quality of life.